Okay, well, thank you so much for having me, and I'm especially delighted because this evening my brother, Dr. Azra Raza, will be giving the History of Medicine lecture, which is an annual event of some note. And it's wonderful to be present here with my sister-in-law Nazli and my brother Syed Raza. Special thanks again to Dr. Amjad Hussain and to the Department of Medicine. So basically our goal as oncologists is to provide those with cancer from the time of diagnosis throughout the course of treatment care that optimizes quality of life by anticipating, preventing, and managing suffering. The question I'm asking is very simple. Are we really doing that or not? Just put this thing away. I want to begin by talking about the case of Umar. In the summer of 2007, Umar developed burning and pain in his left arm, weakness developed in the arm, and a trip to the emergency room eventually revealed a highly malignant osteogenic sarcoma. Following resection, pathology revealed that cancer cells had already invaded blood vessels. In the next 16 months, Umar underwent 7 major surgeries as slices of his arms and shoulders, parts of both lungs were removed. Each surgery was followed by chemotherapy, radiation therapy, immune therapy, more chemo, more radiation, more immune therapies. He suffered unbearably painful toxicities of each, and the tumors continued to grow. Alas, we failed Umar. He died on January 21st, 2009. Umar was 38 years old at diagnosis. And Umar was also the brilliant son of one of my best friends, Nahid, a graduate of Oxford University and Columbia, teaching at John Jay College in New York. This young man had simply the most painful death imaginable. So the question is, were the treatments appropriate given that his chances of survival were essentially zero when we knew that he already has cells that have escaped? Then what would be the alternative if we didn't give him this treatment? The problem is that the end game in cancer is also extremely painful, extremely so. And so the choices that this young man was left with are basically either you die of the disease or you die of the treatment. Why are these the only choices we are offering our patients? We are proudly declaring God-like technology. We are cutting and pasting DNA. We are talking of producing designer babies. In this day and age, it is horrifying to think that the treatments for cancer remain Paleolithic. They belong to the Stone Age. The question I'm asking is, after spending hundreds of billions of dollars on research and millions of publications later, why are we still using the slash, poison, burn approach to treat cancer? My personal experience is that in 1977, when I came to this country, I was treating acute leukemia with 2 drugs, popularly known as 7+3. Today, in 2019, I'm still treating AML with 7 and 3, with the same dreadful results. So what have we done in these last 40+ years? Today, only 3 to 5% patients enter cancer trials. 95% of these trials fail. survival as an endpoint for cancer trials has reached a new absurd level. Under intense pressure from the public and cancer advocacy groups, the FDA lowered its bar of approval for an agent to a bare 2.5 months of extension in survival. 2.5 months. Even with that low bar, only 1 in 5 drugs approved between 2014 to 16 improved survival by 2.5 months. Only 1 in 5 drugs. In fact, 72 new anti-cancer drugs were introduced. They prolonged survival by 2.1 months compared to existing drugs. 2/3 of cancer drugs approved in the last 2 decades have shown 0 improvement in survival. Anyway, think about, even if the drug met its endpoint of 2.5 months, what would that mean to a 38-year-old? And at what cost to his body? This just came out last year, an eye-opening study where in this longitudinal study, 9.5 million newly diagnosed cancer were assessed for this 12-year period, 9.5 million Americans. At year 2, 42% had depleted their entire life's assets. It is absolutely obscene that not only do they have cancer, they become financially ruined and no one is cured. Long-term insolvency for practically 40% of the patients who are diagnosed with cancer. There is a crisis in oncology. Why this abysmal failure? Well, of course, complicated disease, no question about it. It's a moving target. Hundreds of thousands of researchers have been studying this disease for decades without coming up with a solution. Why? Because, very simply, there is clonal evolution. Let's say this is a normal cell. During the process of doubling its DNA, it can make copying errors. And that error can result in what we call a mutation. The problem is, every time now this cell has become a cancerous cell and it starts doubling faster than the normal cell. But each time it doubles, it has a 50-50 chance of picking up new mutations because copying errors are going to keep happening. And so now you have another mutation and then another mutation, a clone with yet another mutation. So by the time, let's say, we got the cancer cells here and began to study them in our lab, and when we came back with the answer for a drug, the disease has reached a different stage, acquired so many new mutations. Each time a cancer cell divides, basically new cancers are potentially being produced. And so, why are drugs failing even when they are developed to target specific proteins? Let me show you in one simple slide. This is, let's say, a bone marrow slide or a liver slide, anything you want to imagine. There's the microenvironment and there are the actual parenchymal cells. One cell acquires a mutation, as a result of which it starts dividing faster, so it expands its clone. This is how clonal proliferation occurs. So now there's a dominant clone, which is a cancerous clone. These cells are dividing like crazy, but each time it divides, there are little subsets with new mutations. Now we come in with treatment, and let's say that the dominant clone was sensitive to whatever treatment we are giving. The cells disappear, the patient enters remission, everything improves, everyone is clapping, hunky-dory. But the response will last only as long as it takes for the next clone to rear its ugly head and start dividing. And this is why none of these treatments are curative. They are palliative at best because of this clonal presence. In other words, it's next to impossible to stay ahead of the curve, is what I'm saying. Another reason for our abysmal failure is that our preclinical testing platforms rely on basically in vitro cultures, mouse models, xenografted models, or genetically engineered mouse models. There are vast similarities and dissimilarities between mice and men. Sexual maturity is reached at 6 to 8 weeks, gestation is 19-20 days, litter size is 5 to 8, life expectancy is 3 years, and this is the thing we are using as a perfect surrogate model for humans. Even the metabolic rate is 7 times greater than that of humans, and just think of this, humans have 70% neutrophils, 30% lymphocytes in our blood. Mice have just the opposite. Why? Because the immune system of mice is developed because they are closer to the ground. So their immune system evolved to defend them against earthborne pathogens. For humans, our immune system has evolved to deal with airborne pathogens. There is a huge difference right there. How can we use those animals as a model system in which we think we have surrogates for humans? Because of failure of mouse models, you would think that people would give up using animals. No, they made more artificial mouse models. So now you have immunocompromised mice, xenotransplanted, genetically engineered mice. In Nature 2017, my colleague Todd Golub from the Broad Institute at MIT published this study which looked at 1,000 mouse models of cancers used as avatars and showed essentially no reliability either way. At the same time, this is what the ex-director of NCI, Richard Klausner, has said. History of cancer research has been a history of curing cancer in the mouse. We have cured mice of cancer for decades and it simply didn't work in humans. Sure, there's a lot of healthy mice running around. This is what we have achieved in the last 40 years. Another reason is this clinical trial system. This just came out on September 4, just literally a month ago. What does this show? The title is Enough with the Me Too drugs. What are the Me Too drugs? Think of this, if a target is identified in cancer and a drug is approved, there is a mad rush to develop drugs for the same target. The Me Too mentality wastes resources and squashes creativity. You're not looking for new targets. Everyone and their grandmothers trying to make a drug to the same thing, slightly different, get it approved, make $1 billion. New treatments should be worthy of the people who invest their lives in clinical trials. This is what Richard Pazder said, who directs FDA's Oncology Center of Excellence. He used the example of checkpoint inhibitors. If there are oncologists in the room, you know what I'm talking about. This is the most fashionable thing to use right now, the immune therapies, the checkpoint inhibitors, PD-1 or PD-L1 inhibitors. 3 well-controlled studies were conducted close together and showed negative results. First of all, why was there a need to accrue patients on 3 separate large trials? Why wasn't one enough? And secondly, 2,250 clinical trials are currently underway testing the same thing. Who are these patients who are being accrued to these trials? Why are we not thinking about them? Patients are not a company's resource. This is coming from the director of the FDA. There's a lot of talk about this very fashionable term, precision oncology. What is precision oncology? The idea is pairing a genetic mutation with a drug. So use genetic testing, identify a mutation, administer drugs that target that mutation, irrespective of the tissue of origin. Sounds wonderful. Sounds like the right thing to do. Well, two types of trials were designed. One are called the umbrella trials, in which different genetic mutations are present in the same organ, the lungs. So you can give, even though it is a lung tumor, looks the same, but because the genetic mutations are different, you give different drugs. And then there's the basket trial, in which the same mutation occurs in the lungs or the liver or the brain or the GI tract. And so you can use the same drug in all these different organs. Being matched, meaning if you have a genetic mutation you found, matching it with the drug, you have a drug, you give the drug. That is not a guarantee that it will work. In fact, only 30% of those patients responded. The median progression-free survival is 5.7 months. So precision oncology benefits around 1.5% patients basically. Foundation Medicine sequenced 18,000 patients. 18,000, you know what that costs to sequence the tumors of 18,000 patients? 32. This is the kind of waste going on in resources. The NCI match trial, in 6,000 patients tested, 6,000 patients, the tumor gene variants occurred with a frequency maximum of 3.4%, 0 to 3.4%. David Hyman from Sloan Kettering showed that of more than 25,000 patients' tumors which were tested, 15% matched with one of the FDA-approved drugs, only 10% with a drug in clinical trials. Vinay Prasad agrees because he showed the same thing in 610,000 US patients. Look at the numbers we are talking about. But once matched, just 6% actually benefit, and benefit for how long? 5 months, 5.7 months. This is the precision oncology that's going on right now. Thousands and thousands and thousands of patients are being entered on these trials. IDH. IDH2 mutations are present in up to 20% AML patients. 199 patients with IDH2 mutations were treated with an inhibitor. 23% responded with a complete remission. That's a good response rate, 23%. But the response is a median of 8 months. It's billions of dollars worth. One of the dirty little secrets of oncology is that most new drugs don't work very well. From 2009 to 2013, even in Europe, they approved 48 cancer drugs for 68 indications. 26 of the 68 were associated with a survival benefit of 2.7 months. And 2.7 months is median. Half the people will get less than that. And look at the fiscal toxicity now. A drug called Tarceva extends the life of pancreatic cancer patients by 12 days at a cost of $26,000. New cancer therapies cost an average of more than $10,000 per month, with marginal benefits for 20% patients. That benefit lasts a few months. CAR T. So much talk about CAR T. In 2017, 2 CAR T cell therapies were approved. Children with ALL. So for one of these indications, it is only approved for people 24 years age or younger because it is so toxic. 24 years old. You can't give it to people above that. Questionable whether they'll ever be effective. But yet everybody is talking about CAR T like it is the next cure for cancer. So many of my patients come demanding, why aren't you giving me CAR T therapy? There's so much propaganda about it. The cells themselves cost $500,000. to prepare. $500,000 per patient just for that, but then you have to admit the patient in the intensive care unit, monitor them constantly. For the neurotoxicity, somebody has to walk in every hour on the hour and make the patient count 1 to 100 and then 100 back, and then ask questions like who is the current president, blah, blah. But then, so that total cost comes to about excess of $1.5 million per patient. How is this affordable? This country, which is the richest country in the world, it is untenable. Where is our social responsibility to the rest of the world? Somebody asked me the other day, Dr. Raza, do you think that in Europe things are better and they don't approve all these things and they are doing better than us? My answer was that here is the main issue we must remember. Everybody in the world looks to America to provide leadership. We are supposed to be leading the way. We are not living up to that responsibility at all, to our own patients and to the rest of the world. Look at cancer publications. More than 4 million papers have been published on cancer, more than 150,000 papers in just 1 year alone. What are they publishing? 150,000 papers. Why is there such a staggering disconnect between what we are finding in the lab and why we cannot translate that into improved therapies for the patients? Bench to bedside translation just doesn't exist. Another reason is this reproducibility crisis. Amgen researchers, Amgen is a big company, they decided to invest money in developing a new drug. So they asked, okay, what drug should we develop? Let's pick up the top 50 plus papers that are published in Nature and Science and New England Journal, and let's try to develop a drug on the targets they have published. Can you believe that they were unable to reproduce the findings in 47 out of 53 of these landmark papers? In fact, more than 70% researchers have tried and failed to produce another scientist's experiments, and half of them failed to reproduce their own. Another reason is cancer and aging are two sides of the same coin. As I showed you, there's a mutation with every cell division. With age, our immune system is becoming a little more decrepit, so there is immune dysfunction. Senescence means when cells get really old and they have multiplied a number of times and they have reached the Hayflick limit, which is about 46 divisions. After that, the cells have two choices, either die down or go into sort of a hibernation called senescence, when the cell dials down its activity to minimum. The problem is these senescent cells hang around and they still have no real function left, but their metabolism is still minimally present. But with age, all these start collecting and they keep producing all this garbage. So the garbage collecting system of the microenvironment becomes completely overwhelmed. Autophagy, completely overwhelmed. And so senescent cells and their presence also predisposes towards cancer. And then tissue loss. Think of it that in a healthy adult around up to 50 years of age, 50% of the cells in the bone marrow are fat cells and 50% are the hematopoietic cells. By the time you are 70 years, it's about 20% hematopoietic cells and 80% fat cells, because you just keep losing a lot of tissue. I call it the mist of aging. M-I-S-T, remember mist. Mutations, immune dysfunction, senescence, tissue loss. This is why cancer is really a disease of the aging. There's about 1.7 million new cases of cancer in adults every year in America. Compare that to children, 14 to 15,000 a year, compared to 1.7 million. So clearly a disease of the, and most of the cancers occur after the age of 50. It's a good example to take. If you start dropping grains of sand, they make a pile. If you keep dropping these grains, eventually this pile will collapse. But the last grain of sand which made the pile to collapse, there was nothing different in that grain of sand than the rest of it. The pile is the one that had become unstable. So even one last grain could just cause an avalanche. So in other words, what I'm saying is that with age, we keep acquiring mutations that are accumulating in our various cells. So the whole system is becoming unstable like this pile. And the ultimate mutation that tips the system from normal to malignant may not have very much different than, but it's this system which has become unstable. So in other words, aging is predisposing us so much to cancer that it's not a simple solution. Thinking that we can take some cancer cells, apply a reductionist approach, which is the pet of molecular biologists, and sit in a petri dish or in an animal model and find a target and kill it with a drug and cure cancer with a magic bullet, I think we have to wake up. That strategy hasn't worked. The only places it worked, chronic myeloid leukemia, where imatinib was developed, acute promyelocytic leukemia, for which we are curing it with transretinoic acid or vitamin A. In fact, these are two rare types of leukemias. And the thing to remember is that because there was success in finding a target, these two leukemias are caused by one genetic abnormality, and so one drug worked in them. But these seem to establish a kind of a model for us that yes, we just have to go and find the same one mutation in other cancers and then we'll find a drug. No. Most other cancers, 99%, have turned out to be far more complicated than that. So very little has changed in 50 years for any advanced cancer. Progress has been incremental at best, and it will take another 1778 more years to cure cancer at this rate. Someone calculated this. Our goals for cancer treatments are set too low. I absolutely reject this idea of prolonging survival by 2.5 months and patting yourself on the back and going around in this intellectual phoniness and giving all these wonderful lectures around the world. No, it's wrong. I absolutely reject this as a model. And also, these treatments that are being developed costing so much money are completely unsupportable fiscally. The whole sand pile in the country has become unstable. Why? I'm sorry, arrogance, overconfidence, contempt. These are the words of the great Robert Weinberg. This conceit that cure is just around the corner. 50 years later, it has not arrived. And I really want to shake up the field and say, it's time to admit that the strategy we have been using is wrong. We've been trying to chase and kill the last cancer cell. What I'm saying is perhaps it's time to look at the opposite end of the spectrum and try to stop cancer before it becomes this end stage monstrosity. Go after the first cancer cell instead of the last. Prevention is the best cure. And I am committed to this since 1984. I came to this country in 1977. I started to study and treat acute myeloid leukemia. By 1984, it was clear to me that in my lifetime, we will not be able to find a cure for AML. And sadly, I was right. Today, we are still using 7 and 3 for this disease. So in 1984, I decided, well, if we can't find a cure for AML, maybe we should look to prevent it. So I turned my attention to those patients who would come with a diagnosis of a pre-leukemia. Their counts were falling, but they still didn't have leukemia. In those days, we started developing this whole concept of these syndromes that were then labeled as myelodysplastic syndromes. These are just conditions in which patients have a higher risk of developing leukemia. So since 1984, I turned my attention to following patients from pre-leukemia as they develop leukemia and see if we can do something to block and intercept this. As soon as I decided to study that stage, I knew I needed cells to study, so started a tissue repository, and now it is the oldest tissue repository in the country. We have more than 60,000 samples from thousands of patients who have been followed for years. These longitudinal multiple samples obtained on patients, and it's a well annotated tissue bank backed by a computerized data bank, and not a single cell in this tissue repository has been contributed by another physician. In fact, to this day, I do all the bone marrows myself. On any clinic day, I'll do 5 to 10 bone marrows. And so many patients who have gone through these painful procedures to give their samples. So, where's my answer? I've been studying for 35 years. Why am I not giving the great answer that I'm criticizing everybody else for? I'm very much criticizing myself also. We are all part of this whole system. In the 1980s, we were so sure that it will be an oncogene. We'll find the oncogenes for different cancers and we'll have the answer. Didn't happen. Then 1990s came, it was choking off the blood supplies. Angiogenesis became a big target. That didn't work out. Then the Human Genome Project started, and we were so sure that once we have sequenced the entire human genome, we are going to find all the mutations specifically present in pancreatic cancer versus colon cancer versus lung cancer, and we'll have better answers. We didn't. And then it took time to develop the technology. It took time to see all these failures happen sequentially, even to me. So we are all part of this together. And we have all been through these cycles of great excitement followed by crushing disappointments each time. And now at least we should wake up and realize that, yes, we continue those strategies, but at the same time try to focus more on earlier detection. Because that's the only strategy we know it works. Don't you know people when they say, oh, my cousin has been diagnosed with cancer, but don't worry, it's a very early stage and they'll be able to cure. So we know that earlier you find, the better it is. In fact, in 1903, Dr. Charles Childers said, it's not cancer that kills, it's the delay in treatment that kills. So we know the earlier we find it, the better. Now, I'm not talking by early detection using mammograms, PSA, pap smears, colonoscopies. Sure, you know that in the last 50 years, there has been a 26% decline in cancer mortality. And that's something to be proud of. But most of it happened for two reasons. Smoking came down and early detection by these things. It's not like we had some fantastic new treatments we developed. Yes, we learned to use chemotherapy and radiation therapy and surgery better, but those remain the three backbones of cancer treatment. Otherwise, it's all about stop smoking and do these annual screening tests. What I'm talking about by early detection is, why are we not using the latest technology to develop new and more refined and sophisticated tests? So imagine taking your morning shower, which automatically scans your body, alerts you to the presence of abnormal cells. How can we do that? Just remember, when a cancer starts, cancer cell divides more rapidly. To divide more rapidly, it needs more nutrition. It makes blood vessels. The area becomes hot. We can pick it up. Your toilet is a fit loo, which can take part of your urine and examine it for abnormal proteins. You wear a smart bra for just an hour a week, which has 200 tiny tactile biosensors built in. This is a clinical trial going on. You exhale into a device and accurately identifies the tiniest molecules that seem suspicious of lung cancer. Once a month, you simply prick your finger and add a drop of blood on a nanosensor that creates a distinct magnetic field in the presence of just a few cancer cells. Or you have a tiny chip installed under your skin to capture, image, and release millions of cells per second. This is what we are working on directly at Columbia University with biomedical engineers. In fact, so many of us are trying to develop what we call the barcodes now. Barcodes for DNA abnormalities, barcodes for protein biosensors that can be loaded onto chips that can be implanted and scanned. All these things are happening now. My case is we should divert more resources to doing that rather than continuing to expend and spend billions of dollars on animal models and going for end stage disease where we only end up hurting most of the patients. The last thing I'll just say is about the tissue repository and the first cell center. Here's the idea that I have had all along. We can study patients longitudinally as they are progressing in their disease from a pre-leukemic stage to a frankly leukemic one. We use the latest genomics, transcriptomics, proteomics, metabolomics, in fact, panomics to study these samples. But just to study, to give you an idea, 200 patients at 2 time points, pre-leukemia and leukemia, 200 patients at 2 time points using just proteomics alone is $4 million. The technology is so expensive. So in order for me to study thousands of patients in the tissue repository by all these techniques, I need at least $100 million. What is $100 million in this country? A football player makes $100 million, for God's sake. And to cure cancer, we don't have that kind of a resource available. This is the important thing. So we study acute leukemia, we are going back to pre-leukemia, and now we see who are the patients who are getting pre-leukemia. For example, 4,000 patients who develop pre-leukemia with a chromosome 5 abnormality had a polymorphism in their germline DNA. In other words, they were born with a certain susceptibility. So what we can do is now, once we identify at that point, this is the polymorphism that appears most commonly in patients with trisomy 8 or deletion 5q type of MDS. Now we simply go to the sequencing banks that are available in the public domain and look at hundreds of thousands of healthy volunteers. Find those patients who have these polymorphisms. Go ahead and see how many of them are developing already. Some pre-leukemic earlier stage than pre-leukemia. So in other words, within a 5-year plan, and any of you who's interested in seeing it can go to my website and just check. I have actually listed each year, year by year, what we can do. Within 5 years, we can go from standing here and having no answer to actually being able to start scanning healthy individuals. Simultaneously, we are developing early biomarkers from the serum. We are developing barcodes for these, screening of healthy individuals. Already I'm working with the Pasteur Institute using this technology to develop circulating tumor cells. Why not a patient with MDS? Why wait for this patient to develop acute leukemia? Because by the time they develop it in the bone marrow, it's too late for treatment. Then we only have 7 and 3 to offer. Why not stop it at just when it's converting in detect that first leukemia cell circulating? This machine is called ISET. And ISET stands for isolation by size of epithelial cells. So we are spending so much money to detect minimal residual disease, any cancer cell left after treatment. And we have developed fantastic refined technology to to identify minimal residual disease. Why not turn all those things to detect minimal initial disease? We can start monitoring the blood of MDS patients, and I've been doing this for 2 years now. for the appearance of the first leukemia cell in an MDS patient. I'm saying that instead of applying annual exams with gross screening tests like mammography and PSA and colonoscopy, we start treating the human body as a machine and continuously monitor it. Right from birth, because who would be looking for cancer in a 38-year-old like Umar? It means that no one is immune from cancer. We need to monitor everyone. Just like vaccination, when a child is born, you just put in the chip. That should be able to detect. So treat the human body as a machine, use implantable and scanning devices. And this is what Sam Sia is at Columbia University, my very brilliant colleague. This M chip is already FDA approved by the company OPCO, which was developed by Sam Sia. This is the kind of microfluidics technology that Elizabeth Holmes from Theranos could not do, because she overstepped and said she could do 100 different tests from this little chip. But at least we can do, so at home you can just put a drop of blood and it tests your PSA levels and several things immediately. In other words, you are at home and you can use this chip to monitor yourself. So let's say I develop a biomarker for pre-leukemia tomorrow, the same chip will work. We just have to change the biomarker that's being detected. This chip is also being used in Africa, in Rwanda, in several countries to detect all the venereal diseases. So you just put the markers for the venereal disease biomarkers, and you detect them in literally, and you can use these as mobile devices. Look at this. Sam has developed this fabulous thing which can be inserted. It's a hydrogel, little tiny machine that can be inserted under the skin and in any organ, where it will deliver the drug. So you just fill the cassette with the drugs that you want to give, and it's going to give it internally. I also have, as you mentioned, Aziz, and that my book has just been published. The idea of the book, though, is a little different, and I end here now. There's a difference between disease and illness. Disease is something that doctors diagnose, that we study. Illness is what patients suffer. And I feel like as doctors, we have become a little removed from the illness part. We concentrate too much on trying to cure a disease, and we are not looking at the human suffering and anguish in all its granularity. And I think that the only way in which we will be shaken to change the way things are being done and get away from this inherent righteousness in the way things are done and try to do something different is once we understand what this suffering is all about. And so let's go back to patients. And so the book is not a book about technology and a book, it's about patients. It's full of stories. And through the stories, I ask some very important questions about why did we do this to Umar, or why did we do this to Andrew? And I'll end with dedicating it to Umar, but with a brief poem from Emily Dickinson. I measure every grief I meet with analytic eyes. I wonder if it weighs like mine or has a different size. I wonder if they bore it long or did it just begin. I cannot find the date of mine, it's been so long a pain. I wonder if it hurts to live, and if they have to try. I wonder if it hurts to live and if they have to try, and whether could they choose between, they would not rather die. This is my best friend Nahid, with the beautiful son that she lost at 38. Thank you.
So they were good questions. If you have any, just raise your hand. I'm going to like to.
The low-dose CT scan and its impact on the lung cancer and its curative rates. How do you think? Has that been an impact? Well,
Very good question. So 3 randomized trials of screening for lung cancer which used sputum and chest x-ray failed to show that you could detect cancer early enough in the lungs. However, low-dose CT scans and MRIs now have shown in smaller studies that at least in individuals who are at high risk of getting lung cancer, that screening does identify early disease, and that it should be something that we should be following. That's exactly the kind of thing we need to be doing.
Thank you for a great talk. I have 2 questions. The first question is, not all cancers are mutation, are a result of mutation. So how do you define early biomarkers and how to bring those patients to the clinic? The second question is about all these devices that you mentioned. Doesn't that entail biomarkers and support for basic research? And what is your take on multi-target biomarkers?
You'll have to remind me of the second question. So let me answer your first question is about genetics. Genetic mutations are not the only reason for cancer. You're absolutely right. My colleague Siddhartha Mukherjee was the first to show that if you change something in the stroma, the parenchymal cells can get cancerous, become malignant. And so it's true that you may not have a genetic mutation, but in the end, the abnormal function of a cancerous cell is determined by genetics, meaning there may not be necessarily a mutation, but a dysfunction, an overexpression of a gene, underexpression of a gene, or some difference in the microenvironment. So we are not looking for just genetic markers, obviously, not just mutational genetic markers, but markers of RNA, protein, as well as metabolomics, the metabolites that are produced by the cell. So in fact, they are called analytes from the serum rather than just a twisted piece of DNA or a mutated piece of DNA. So the answer to your question is that I don't believe that any one technology will be the ultimate answer. We will have to use a combination of things. That, for example, with the bed sheets, you find a hot spot. That doesn't mean you go like crazy and try to treat it immediately. No, then you have to follow it up with a number of other technologies to make sure, is there the protein being produced that is expected? Is there a genetic mutation, etc.? So that's the answer to your first question. And your second one is?
My second one is about looking at multi-target and early biomarkers support for basic research instead of, in order to use all the devices that you mentioned, we need to look at early biomarkers, and that entails support for basic research. And also I asked about, inherent in that question is what's your take about a multi-target approach instead of looking for only a single marker per disease or per setting?
Absolutely, I agree with you. Multi-targets have to be explored. But the answer about more money for research, I'm allergic to that, because there is plenty of money going into research. It's just going in the wrong research.
So how are you going to use the devices then that you mentioned? All these neat devices that you listed, without looking for a marker, how are you going to?
No, I'm not. No, we need to look for markers. I'm saying the money we save from wasting on, say, studying 2,200 clinical trials for one target. Think of the billions of dollars we'll save from there and invest it in looking at exactly what you're saying. Try to look at human tissue, study the human body, try to find human markers, and try to use all the technology, including implantable devices, scanning techniques, biomarker detection. All of these things have to be studied and brought together. And believe me, in the next 10 years, it will come. The revolution in healthcare is coming, because everyone realizes that what disease have we really cured besides infectious diseases? Very few. We still have the same diabetes, the same, the heart diseases are only early detection and prevention. They became smarter than us before and started taking care of things early. I think all of healthcare is going in that direction, and yes, we need to do all the things you're saying. I'm not saying we should study any one thing.
Thank you for the great talk. My questions are related to the end stage. You talked about using pan-omics and these newer devices to do early detection, like even before. So you talked about myelodysplastic syndromes before they turn into AML, for example. Any data you get, any potential marker that you get is going to be a probabilistic estimate. And the uncertainty increases if you're just looking at one disease, it's 1. If you're looking at 2, 3, 4, the uncertainty will keep on increasing. So how do you account for that if you're looking at 6 different types of cancers in the genome, in the metabolome, in the transcriptome at the same time? The more technology, so this is a mathematical problem with this approach. How do you think that works?
It's not going to be easy, I agree with you, but I would rather deal with that problem than treating thousands of patients with chemotherapy for nothing. I'm not saying I have all the answers at all. And yes, we will end up with a systems biology approach. But look, my thing is that in America, we have enough of a brain drain, young people like you with such smart minds. If we set a target and we properly financially incentivize that target, everyone will go to it and problems will occur. You'll have to solve them when they come. I'll be very happy trying to solve the problem of how do I deal with 10 beautiful markers I found for 10 malignancies rather than doing what I'm doing today and what I've been doing for 40 years.
Dr. Raza, congratulations on this fantastic talk. I enjoyed your history of medicine talk 2 years ago, so it's great to hear you again. Now, you have been involved in the moonshot by Biden, so what's the status of that now?
About, sorry?
The moonshot.
Yes.
You were involved in the early
Yes.
discussions on that.
Yes. The moonshot got hijacked by the same people.
So it's all feasible.
He has actually withdrawn completely.
Oh, yeah?
Vice President Biden announced that he is no longer going to pursue that. But it was completely taken apart, although some of the moonshot money is going to early detection. I shouldn't say that. Some is going to.
That's good. Thank you.
I just have some comments, if I may. You
Please.
have opened our eyes to look at cancer from a different perspective. As a surgeon, at one time, I thought the most extensive the surgery, the better the results, and of course, the Halsted and all the other operations we did for breast cancer and likewise did not pan out. Still, at least in my field, surgery, that we think that when in doubt, cut it out. But unfortunately, we can see only a macroscopic appearance at the time of surgery. we have no inkling as to what's happening at the microscopic level. And so we have been fooling ourselves, going out and telling patients, I removed the cancer, of course I removed the cancer. But that's only a euphemism. We did not remove the cancer. Hence, the results have been dismal. I also want to comment on your statement that we are spending a hell of a lot of money towards the end, the natural history of cancer, and all the fancy medications we have, we get 2.5 months of miserable existence. And of course, the bankruptcy and losing your assets in the meantime. So it requires a radical reassessment and changing the focus. I had heard parts of your talk before. You were a visiting professor here at the Department of Medicine, gave grand rounds on that subject. And I thank you very much that you made the time. By the way, Dr. Raza, we snatched her because she was flying from New York to someplace for the book selling or the book signing ceremony, and we just snagged her to come to Toledo. She is going to have an extremely busy next few months on her book tour, which is the first step.
Thank you, Amjad. By the way, in my family, my brother is a cardiac surgeon also, and we don't want him to develop the godlike syndrome. So we are always teasing him. For example, my younger sister would ask, Appa, what do you call two surgeons looking at an EKG? I would answer, a double-blind study.
The surgeons are not that bad, by the way. I thought those were just your
Only cardiac surgeons are.
I thought those were just your
No, we love surgeons, we respect surgeons. In fact, 67% of cancers today are cured by these techniques, surgery and chemotherapy and radiation therapy. 67% are cured.
So just a quick question. I call it the currency of life. In your question, for example, here, for a patient who has pancreatic cancer, they've done 2 months, and the 6 weeks survival usually is really bad. But if you tell somebody, I promise you to live 2 years, what kind of 2 years? So we're talking like, oh yeah, I can give you 200 years of life, but you will live without a brain, you will take 2 hands off, and the 2 legs off, so you will be just a torso body. The question is that equivalent to a real 2 years of life or 3 years of life? If you tell a physician, oh yeah, okay, you had a stroke, you will survive till the 60s. Will he say, oh, I don't know what's the currency that you're talking about? Survival is not equivalent to survivable function. So the question, is there in cancer research something that is talking about the quality index of life? So I'm saying, okay, this, especially when I'm talking to a patient who has stage 4 cancer, and the oncologist comes to me and say, oh yeah, he will have a period, the mortality rate is, or the 2-year survival is so and so. Is this a real 2 years of survival or 2 years survival with complication? So again, I transfer that to dollars. If I'm giving you $1 to live this day, is it truly worth that dollar?
Yeah.
The same things like mortality. It's like, oh yeah, somebody would want to go even in chemotherapy because he thinks the value of that chemotherapy is not worth to live. So he prefers to live 6 days over 6 months. And I think that's, nobody will talk about, also, nobody will talk about kind of quality survival. Everyone's talking about survival only.
Yes.
So when you have a discussion with oncology, I'm pulmonary critical care, so I have difficulty.
Yes.
I'm talking to my patient who has lung cancer in stage 4. Oh yeah, the oncologist comes to me and was like, oh yeah, he has a good survival rate. he will live like 6 more months extra on next drug. But to him, it's like, did you know what are the risk factor, the side effects of the drugs, and is it truly you're living out of the hospital, or it's inside the hospital for 6 months? So the difference is great. I don't want to live a single day after a stroke, even if you promise me 50 years.
I agree. I think you've raised profound issues. I agree.
This is one last question, and then we'll wrap it up.
Okay, thank you very much for the great talk. So, in terms of the personalized treatment, you mentioned that the mouse model is not reliable. So, what's your opinion about using other animals that's more close to human, like a monkey or other animals?
I'd like to make one thing very clear. I think mouse models and all animal models that we use are very useful as biologic tools. The only thing I object to is using these models for drug development. We can take a gene and we can study its function and things like that in an animal model. That's using it as a tool. It's fantastic. But we can't give a drug to a mouse, and if the mouse responds, we think the same will happen to humans. That's what I'm against. The same criticism applies to every animal. The best model for a cat is another cat, preferably the same one. That is a well-known saying, and that's exactly right. We cannot use anything but, I see 30 to 40 MDS patients every week. This is a rare disease, but patients travel from all over the country to see me. I have been seeing MDS for 35 years now. 30 to 40 patients a week for 35 years, yet every patient is unique. Their natural history is different. I don't start treatment on anyone unless I have followed the natural history of that patient's disease, watched how it's behaving, because I can't apply what I learned from 10,000 other patients to this one. So the idea is using any of these to ask a question like, do you think another animal is a better model? No, I don't think so. In fact, it is deluding ourselves. We think that we'll be able to study diabetes in animals and cure it in humans. We haven't. We haven't done anything with any disease. And so, in fact, I hope that the book I have written, The First Cell, will have impact on many other fields besides cancer, because in every field it's the same issue. They do trials in sepsis in hundreds of thousands of animal models, and then they bring it to the bedside, everything fails. Whether it's sepsis or burns or anything you take, the same animal model problem. All the brain studies they're doing in animals and trying to apply it to humans. So I just feel like we have been taken for a ride. We need to stop this.